Welcome back to NCLEX PNRN Prep. Let's practice thinking like a nurse. Subscribe for weekly clinical scenarios.
Today, we're exploring a fascinating case of antiretroviral drug toxicity. Specifically, we're looking at a dangerous interaction between certain medications that creates this wild paradox of failing immunity. It's a story about what happens when the very drugs designed to save a patient's life literally start a biochemical domino effect that threatens it instead. Now, I want you to think about this question. If an HIV patient's viral load is completely suppressed, meaning, the antiretroviral therapy is doing exactly what it's supposed to do, why on earth would their immune system suddenly start failing? It totally challenges everything we intuitively know about HIV treatment success. Usually, when the virus is undetectable, those CD4 T cells are supposed to rebound. But in this explainer, we're going to examine a scenario where those CD4 counts paradoxically plummet. No way, right? Let's figure out why. Here's a quick look at our roadmap for today. We'll start with our deadly clinical paradox, break down the pathophysiology, and sift through the diagnostic clues. Then we'll cover medical management, critical nursing care, and wrap it all up with prevention strategies and some high-yield NCLEX pearls. All right, Section 1, a deadly clinical paradox, the 22-year-old patient. Let's look at the real-world scenario. Okay, let's dive into this timeline. 18 months ago, this 22-year-old female was diagnosed with HIV and initiated on highly active antiretroviral therapy, or HAART. And initially, it was a massive success story. Her viral load dropped to completely undetectable levels, and her CD4 count rebounded really nicely from 185 up to 311. But then, about 10 months ago, this subtle, dangerous shift happened. Even though her viral load stayed completely suppressed, her CD4 count just started this progressive, unexplainable drop. And today, well, she presents to the clinic not just with failing immunity, but with severe epigastric pain radiating to her back and severe nausea. So what's going on? What we're actually looking at is HAART toxicity. More specifically, this is an iatrogenic or medically induced complication caused by co-administering two very specific reverse transcriptase inhibitors, Didanosine, known as DDI, and Tenofovir, or TDF. Basically, this exogenous chemical insult causes two distinct systemic toxicities, a paradoxical CD4 decline and acute severe pancreatitis. Moving on to Section 2, pathophysiology of heart toxicity, the biochemical domino effect. To really grasp this, let's break this dense biochemistry down into a three-step cascade. This brilliantly illustrates how one drug messes with another. Step 1, Tenofovir actually inhibits the PNP enzyme. And because Didanosine relies on that exact enzyme to be broken down, it simply piles up to toxic levels inside the cell. Step 2, this massive accumulation completely disrupts the cell's purine salvage pathway, depleting vital building blocks called dNTPs. Without those, CD4 T cells literally cannot divide, so they die off. And Step 3, these toxic levels starve the pancreatic cells of ATP, leading to a structural breakdown and, terrifyingly, the premature autodigestion of the pancreas. The absolutely crucial number to remember here is 165. Because of that impaired T-cell proliferation we just talked about, our patient's CD4 count has completely collapsed from her baseline of 311 all the way down to 165 cells per microliter. So despite having zero detectable virus, this drug reaction has placed her in immediate severe danger of opportunistic infections. Section 3, Diagnostics and Clues, Solving the Mystery. Let's put on our detective hats. Let's look at the labs. Her serum lipase and amylase are elevated, more than triple the upper limit of normal. That right there confirms acute pancreatitis. But the real aha moment comes when you combine that with her HIV-specific labs. Her viral load is less than 25 copies per milliliter. It's undetectable. That completely rules out virological failure or the patient skipping her meds. Yet, her absolute CD4 count is progressively declining. When you put those three clues together, they definitively point away from HIV disease progression and point directly toward drug-induced mitochondrial and lymphotoxicity. Which brings us to Section 4, Medical Management and Treatments, the rescue. How do we stop this train crash? The absolute very first step is to instantly pull the plug on the offending agent. We have to discontinue Didanosine to stop that enzyme competition. But we obviously can't just leave our patient without HIV treatment, right? So we transition her to a safer antiretroviral backbone. We keep the tenofovir and efavirenz, but we substitute zidovudine, or AZT, in place of that toxic DDI. Now, beyond just fixing the med list, we have an acute medical crisis to manage. These are the immediate medical orders. First, bowel rest. We're talking strict NPO status. Second, aggressive IV fluid resuscitation using isotonic crystalloids like lactated ringers. This is an absolute must to maintain pancreatic perfusion and stop tissue necrosis. Third, we need to get ahead of her pain, so we use IV opioids like morphine or hydromorphone. And finally, because her immune system is dangerously compromised right now, we immediately start cotrimoxazole prophylaxis.
Section 5. Nursing Care and Education. Theory to Practice.
Let's translate that complex pathophysiology right to the bedside. These 4 nursing diagnoses frame our care plan around the patient's absolute most vulnerable areas. First, acute pain related to that pancreatic inflammation and autodigestion. Then, deficient fluid volume from third space fluid shifting and nausea. We also have a massive risk for infection because her CD4 count is well below 200. And lastly, deficient knowledge regarding all these sudden scary regimen changes. So, how do we tackle the pain and pancreatic damage? We enforce strict NPO status. And keeping the patient NPO isn't just about resting her stomach. It's a highly targeted intervention to minimize pancreatic stimulation. If we prevent the pancreas from secreting digestive enzymes, we literally halt the autodigestion process. We're giving the organ the break it desperately needs to recover from that mitochondrial toxicity. Now about that infection risk. This is so critical. A drop in CD4 cells below 200 places this patient at incredibly high risk for severe opportunistic infections, most notably pneumocystis jirovecii pneumonia, or PCP. And the kicker here? She is vulnerable regardless of her beautifully suppressed viral load. The CD4 numbers alone dictate the risk, which is exactly why getting that cotrimoxazole on board as a prophylactic is a complete non-negotiable priority. And before she ever leaves the hospital, education is our final shield. We have to make sure she understands why the DDI was dropped and emphasize strict adherence to her new TDF, AZT, and EFE regimen to keep that virus suppressed. We also need to teach her the early warning signs of pancreatitis, things like persistent nausea or abdominal pain that radiates to the back. We have to lay down the law on strictly avoiding pancreatic irritants, meaning absolutely zero alcohol and avoiding over-the-counter hepatotoxins. Plus, strict infection control and hand hygiene are a must while we wait for those CD4 counts to bounce back.
Finally, Section 6, Prevention and NCLEX pearls.
First off, let's understand the stakes here. If this specific heart toxicity slips under the radar, the complications are just catastrophic. We are talking about severe tissue destruction that leads to pancreatic necrosis and pseudocysts. That intense, localized inflammation can easily trigger systemic inflammatory response syndrome, or SIRS, which can progress right into ARDS. The low CD4 count invites severe, deadly opportunistic infections, and the mitochondrial inhibition, that can trigger fatal lactic acidosis. So, the crucial point is this. If you are prepping for the NCLEX or managing patients in real life, burn this absolute rule into your brain. Never administer Didanosine and Tenofovir together due to the severe risk of fatal or near-fatal pancreatitis. You have to avoid co-prescribing them whenever clinical alternatives exist. Just don't do it.
And that brings us back to the core lesson of our clinical mystery today, the paradoxical CD4 decline. If you ever have an HIV patient whose viral load is brilliantly suppressed, but their CD4 count is mysteriously tanking, you have to look beyond the obvious. Do not just automatically assume they're skipping their meds or that the virus is suddenly mutating. You need to investigate drug toxicity. So, I want to leave you with a thought to chew on. We've just seen how 2 medications, both designed to suppress a deadly virus, can interact to create a devastating failure of immunity and organ function. It kind of makes you wonder, right? What other seemingly safe medication combinations out there might be hiding a dangerous biochemical cascade? Always question the labs that don't make sense, and always respect the power of drug interactions.
Passing your board exam isn't about memorizing everything. It's about learning to study smart and think like a nurse. Every week, we break down high-yield topics into simple lessons, unfolding case studies for clinical judgment, NGN practice, bow tie, matrix, and prioritization. Bite-sized stressing and hit subscribe. Let's get you licensed.